This is a bit of a more specialized topic. Really talking about sacral fractures and spinopelvic trauma, and perhaps in some ways belongs to pelvic fracture as well as anterior ring injury, the symphysis disruption, and acetabular fracture. So this kind of highlights how sacral fractures can be part of pelvic ring injuries, part of spinopelvic injuries, kind of closer to pure spine injuries, or most frequently a combination of all of these. And although this talk is more geared towards the spine component or spine surgery component of it, this is something that really you can't really isolate one from the other. And to that end, you have to keep in mind also that these patients tend to be involved in high energy injuries, and they generally need to be stabilized from a hemodynamic standpoint and be triaged appropriately and evaluated as far as the extent of their injury and potential for occult open injuries, whether involving the genitourinary tract, the alimentary tract, or just through the skin as well. And hemodynamic measures can be taken to stabilize the pelvis provisionally for hemodynamic purposes, as you can see using a circumferential sheet. But one of the things that has to be kept in mind is you have to do a thorough neurological exam on these patients. This applies to really all spine trauma. I think one of the things that is especially important in sacral fractures, because someone can seem neurologically intact but have a profound neurological deficit if they're not evaluated with a rectal exam. They can have an isolated sacral root injury, particularly with sacral fractures, and that needs to be known in order to manage these patients. So it's essential in these patients. From a radiographic standpoint, plain radiographs alone, particularly when there's no pelvic ring deformity, it's quite easy to miss sacral fractures, even displaced sacral fractures. And until we started in the U.S. and in our institution using CT scans routinely, pan scans, or abdominal pelvic CT scans routinely with reconstructions of the sacrum, it was actually not uncommon for us to miss these injuries, whereas now it's really quite rare. So as far as classification, I think the most commonly used is the Denis classification, which divides the sacrum into three zones relative to the foramina, and lateral to the foramina tend to have the lowest likelihood of neurological deficits, involve mainly L5 lesions, and then within the foramina, involving the foramina, but lateral to the canal, tends to have the second highest, involves primarily L5-S1 injuries, and then anything involving, in general, the spinal canal tends to, first of all, have a higher risk of neurological deficit, and because it tends to involve the roots bilaterally, a high risk of Cauda-Equina syndrome. But there's one deceptive thing in the way we interpret this classification scheme, is that if you truly have a longitudinal fracture through the sacral canal, which is extremely rare, you can see 0.6% of all pelvic fractures, these tend to be actually fairly benign injuries. They don't behave like the other zone 3 injuries. And so when we're talking about zone 3 sacral fractures, we're really talking about these types of injuries. They're multiplanar injuries. You have a transverse component, you have displacement, and you have shear injuries to the nerve roots and compression of the nerve roots. And you can see the classification by Roy Camille has delineated these a little more carefully. And we tend to look at these as H fractures, U fractures, lambdas, T's, etc., colloquially, depending on what their pattern is. But the common unifying feature to these is they tend to have an instability pattern where the spine, including part of the sacrum, usually the central part of the sacrum or the central upper part of the sacrum, tends to dissociate itself and displace itself from the rest of the pelvis, and that's where the term spinopelvic dissociation comes from. There's a new classification that the AO spine has developed, and I know this is a very wordy slide. You just need to pay attention for this purposes to the yellow parts, where, as usual, the AO classifications A, B, and C. The type A injuries, the type A sacral fractures, have no impact on either posterior pelvic or spinopelvic stability. Type B injuries impact pelvic stability, posterior pelvic stability, but not spinopelvic stability. And then type C injuries impact spinopelvic stability and even potentially posterior pelvis stability. And here's an example of these. So A1, A2, and A3, how do they not impact either the posterior pelvis or the spinopelvic junction? Quite simply, they're below the sacroiliac joint. So if you have a fracture below the sacroiliac joints, you don't disrupt a weight-bearing line between the lower extremities and the spine, and therefore you don't dissociate the spine from the pelvis. They can be injuries that require reduction and instrumentation, especially if they're displaced and have neurological deficits. but they don't have the same stability implications. Type B injuries are essentially variants of the knee classification in terms of being longitudinal fractures that are primarily a posterior pelvic instability pattern. There's a little bit of a change in the alignment because if you truly have this vertical fracture that involves the spinal canal, it's actually more benign than these two, so we actually place those as the least severe in the hierarchy of B1 to B3. And then you have the type C injuries. These are the ones that have spinopelvic instability. The non-displaced fractures, C0, are generally insufficiency fractures seen in elderly patients, so they're kind of a different animal than the rest of the fractures. If you have a vertical fracture that involves the facet joints or dissociates the S1 facet joint, you can have a spinopelvic instability due to that, less severe than if you have bilateral foraminal fractures, or bilateral transforaminal fractures, or H or U-type fractures that also involve a transverse component. And these are the primary focus of this presentation, these C2 and C3 injuries. Can you treat these non-operatively? Well, it's certainly been done. This is a case from over 20 years ago at our institution that was treated non-operatively, probably the last one that I can think of treated non-operatively. You can see that there's a reasonable reduction. This required bifemoral traction for 6 weeks in a patient who tends to have, like many of these patients, a significant rate of abdominal, thoracic, closed head injuries, etc. In 2015, these are probably not the types of patients we want to treat non-operatively. These are patients we generally want to decompress if they have neurological deficits, which is the majority of these patients, and this can be done either through a direct decompression like laminectomy and foraminotomies, and as well as an indirect decompression, which involves reduction of the fracture fragments, which realigns the sacral tunnels and decompresses the nerve roots as well. As far as stabilization principles, it's generally advantageous in these circumstances to fix the anterior ring first, if there's an anterior pelvic fracture, and then to achieve the required length in order to reduce the sacral fracture, and then eventually realign the posterior pelvis and the spinopelvic junction, and then you have to hold it all together, right? And so how do you hold it all together? Well, there are a couple of options that are most commonly used in our institution. A study by one of my colleagues, Sean Nork, 15 years ago now, demonstrates the value of percutaneous fixation techniques, iliosacral screw fixation in these patients. Tends to be most useful in patients with lower grade injuries. Less displacement allows for a consistent safe zone. As well, these patients tend to have lower likelihood of neurological deficits, lower need for open decompression or open reduction. And the disadvantages are you get really very little reduction, and so it doesn't work well for highly displaced fractures, and these patients don't tend to be mobilized quite as aggressively, which can be a problem in polytrauma patients. Does it provide enough stability? Well, usually in those circumstances, yes, but one of the problems is sometimes you don't know until it's too late that it doesn't. And here's an analogy, is you have a situation where this car needs to be removed from the bay, and so you want to mobilize sufficient resources but not excessive resources. So you apply this truck or deploy this truck to the scene and then realize, oops, you probably didn't do enough, and that you actually needed a little more of a heavy-hitting truck, and so you bring in the big guns to fix the problem. And unfortunately, we do run into this problem with these spinopelvic injuries. An example here is this young patient, bilateral. You see he has bilateral transforaminal fractures, which are the main problem because the transverse fracture is well below the SI joint, but it's a form of spinopelvic dissociation treated with 3 iliosacral screws, and you can just see here in the bottom right here, you can see that the screws are starting to bend as he displaces, and he displays the usual instability pattern. Right, so he's demonstrating how these fractures tend to displace, and this was just simply not sufficient fixation for him. And so the other option that we tend to use, if we don't think iliosacral screw fixation was enough, or if we find out that it wasn't enough, is spinopelvic fixation, where if you look at the shaded areas represent the 2 primary fracture fragments that extend, where you can extend instrumentation above and below in these sacral U-type patterns. And this is generally done for the more unstable injury patterns, the ones you have to open, reduce, etc. And it does this fixation, which is also a form of triangular fixation. It's been dubbed in the past when it was used unilaterally. Is biomechanically more stable. You tend to have less displacement for unit force.